So this is Kaylee Tileston. She's going to be presenting on debate around growing spine constructs and the pros and cons of these operations.
All right, so we are going to go from the very, very old to the very, very young. My name is Kaylee Tileston. I'm a pediatric orthopedic surgeon, and we're going to talk about growing spine constructs today. So I don't have any financial disclosures that are relevant to this talk. I wanted to start with a case for discussion. This child showed up into our clinic at 3 months of age. These x-rays were taken at 3 days of life. She had a very complex medical history already when she showed up to us. She was very small for gestational age. Phenotypically, she looked like she had diastrophic dysplasia. She had severe microrectognathia requiring a trach right after birth, and then she had already had a G-tube placed at 2 weeks of age. So when you look at these x-rays, you see she already has non-congenital scoliosis. She has short limbs and then bilateral dislocated hips. And so, when you look at her ribs are already deformed, and she's only 3 days old. She had such a significant initial course that we weren't able to do anything at this time. We saw her back at a year of life. Her curvature has worsened a little bit, but she doesn't have significant kyphosis yet. And then we talked to the family. Oftentimes for kids like this, we might consider casting or even bracing. But again, she was so small that we didn't feel like we would be able to get basically around her other devices that she was using. We elected to keep following her. At 3 years of life, you can see that she's got significant pulmonary hypoplasia, and her curve is starting to worsen. And then finally, at 4 years of life, you can see that her curvature is now over 90 degrees. I did put up here, though, her growth chart. So she is under 20 pounds at this point. She is 24 inches tall, and she's got severe kyphosis. So the question is, what do we do about this child? And these kids with early onset scoliosis are a real challenge for us. So oftentimes they have very small stature, they have lots of underlying health problems, and their deformity occurs very early and it tends to progress very, very rapidly. And so our goal is to get three-dimensional correction of their curvature and try to keep them balanced over time so that their lungs can grow. And this is important because in the first 5 years of life, you get this rapid growth of the size of the lungs. So the actual height of the thorax is, by 5 years of age, is about 50% of what it's going to be at the end. And then that reaches 100% by 10. The alveoli actually, you can see this exponential growth, and by 8, they have developed to their final stage. And then the overall thoracic volume, that takes much longer to develop, and at 10, they're only about 50% of where they are. And so what we want to do is try to support them because it's sort of this domino effect when you have these severe deformities. The deformities make the chest smaller, and then that causes the alveoli to not develop, and it creates more and more issues for them. As the chest is smaller, also there's less compliance of the tissues, and so they're not able to take as deep of a breath as they might otherwise be able to. This leads to thoracic insufficiency syndrome, which is where kids actually, they can't breathe just to support their normal everyday life. And so their low lung volumes it's both intrinsic and extrinsic. So intrinsically, their alveoli are less than they should be. And then the muscles that help support deep breathing don't function quite as well. And so with that, they tend to take very shallow breaths, and therefore they have to breathe very rapidly in order to get the correct minute volume. And then with that, that means that it's very hard for them to eat because they can't breathe and eat at the same time, so then they oftentimes are very poorly nourished, and this can lead to respiratory failure and even death. And so there's two school of thoughts of like how to treat this, and one is you want to try to do something early, and the question is do we do that early so that we can give them the growth that they need to support their lung volume growth? And then the second one is, do we try to get them as far along as possible before we do anything, because there's risks with intervening early. So with that, we need to understand what the risks of progression are. We look at a couple things radiographically that help us make that decision. The first is the rib vertebral angle, and the second is the rib phase. So the rib vertebral angle is perpendicular to the vertebral body, and then you measure the difference between the convex and the concave side of the ribs. If that difference is less than 20 degrees, it's unlikely to progress, and about 85% resolve on their own. If it's more than that, then those have a higher risk of progression. And then the rib phase, as you see here, if you look on the convex side, if the rib head is not overlapping the vertebral body, that's a phase 1, then those tend to do much better than those, as you see on phase 2, where they overlap their vertebral body on x-ray. So if you see a rib vertebral angle difference of more than 20 degrees, a phase 2 rib, and a curve of more than about 25 degrees, those kids have a very, very high risk of progression. And so the early onset scoliosis community tried to classify this, and they created this classification system that looks at all the things that sort of really determine the risk for progression. And that's age, etiology, whether it be idiopathic, neuromuscular, or congenital. What's your major curve angle that you're starting with? What's the curve, or what's the kyphosis? And then really importantly in this yellow is what's the progression? And so you can have a very large curve, but if it's stable and being able to be supported by a brace or a cast, then you don't necessarily need to proceed to any surgical intervention. Whereas if you have a moderate curve, but they're progressing very, very rapidly, then your hand may be forced to a more early surgical intervention. And so again, it's a fine balance for these kids. Pulmonary function, the faster you intervene, the more likely that they are to have a larger chest wall, to develop the lung function. However, if you wait until they're older, you can get a larger implant in, you have more soft tissue coverage, and the patients, you don't have to lengthen as many times. So previously we used traditional distraction rods, which I'll show you. And those, you have to go in every 6 months and lengthen them. And so we know that if you go in about 7 times, you have about a 50% chance of a complication. Whereas if you go in 11 times, then it goes up to about 80%. So the earlier you start, the higher your risk of a complication. And so historical context for this, on the left, we started with Harrington rods. Harrington developed this. It's just a single unit rod connected at the top and the bottom, and he would go in and lengthen. Lukey sort of took this and thought, well, maybe I'll just harness the growth of what the child is already doing. So he placed sublaminar wires as shown here, and that is sort of the guided growth philosophy where you grow up the wires. And that's led us to what we have today. And so today we have surgical options, and we classify them into 3 categories. The first is distraction-based. The second is compression-based, which we won't talk about so much today. And then the third is growth-preserving. And so before we start any of these, most of the time, if we can, we try to put these kids in a halo. The reason being is because a lot of them have very significant kyphosis, and this kyphosis can be stretched out slowly over time, and they can stay in a halo for weeks or months. This allows them to eat, so they have more chest expansion so that they can breathe better. They have more energy. They're in the hospital usually, but they can go home with this. So they can get nutritional support and get their nutrition levels to where they need to be. So this child of mine, she was in a halo for about 4 weeks. Prior to being in a halo, had difficulty just walking. We could not get her nutritional intake up to what it would be. She's in this halo and she's like running around the wards and like having the best time because she can actually see in front of her and not be looking down. So the kids actually love the halo. The kid that we were talking about with the diastrophic dysplasia, we also put that child in a halo. You can see it doesn't correct the coronal deformity very much, but it does help with her sagittal deformity quite a bit. And then for this child, we elected to go with the sort of tried and true distraction growing rod. The way that a growing rod works is you have fixation points above and below, and then you make your rods a little bit long so that over time you can lengthen. So you can see that distally the rods are a little bit long. You go in about every 6 months and lengthen them. This is a surgical procedure. When you do this, you want to make sure you have at least 5 points of fixation proximally, because that decreases the risk of pullout. You can see here, we'll talk about rib versus vertebral body fixation. For her, because she was so young, we did choose to use rib fixation, mostly because her vertebral bodies were so small, and we wanted to create a native area that we could go back to as a bailout if and when she needed another surgical procedure. And so for her, she wasn't a candidate for any of the other options. At the time when she came in, magnetic growing rods was a really big thing. It had just come on the market, and we thought it was the best thing since sliced bread. But she doesn't have a flat enough segment. She's too short to be able to fit the actuator in there. So she ended up getting this, and we'll follow her over time. The next option that we talk about is the sliding guided growth spinal system. The way that works is you fuse at the apex, and then you have these polyaxial screws above and below, and that allows the spine to grow off of the screws. So the screws engage the rod, but they don't fully lock it in place. That's sort of in line with what the Lukey trolley did. When we look at the difference between the traditional growing rods and the sliding guided growth, the guided growth does require fewer surgeries overall because you're not going in every 6 months to lengthen, but it does result in more unplanned surgeries. The complication rates are very similar. What specific to this, you see a lot more screw loosening or pullout because the patients tend to kyphose over the top. Also, as you can imagine, these kids are very small and tiny, and so when you leave the rods really long, then you have this prominence of the rod itself, and that can cause skin breakdown, especially proximally. You can see rod fracture, and oftentimes you'll see metallosis. So these kids do have a much higher risk for complications, and so we don't do this quite as much as you might think. The other option is a vertebral expansion thoracoplasty. This was initially invented for patients with congenital scoliosis, especially those that have rib fusions. It's really nice because you can take down the rib fusions and then you distract to try to make the thorax itself bigger. It's really nice because it avoids the vertebra, but as you can imagine, these implants are quite prominent. So when we look at your 4-rod implants as pediatric orthopedics, we're very impressed that you can get all of that hardware in there. For us, these are really hard to get covered. These have a higher rate of infection, and then when you're pushing against the rib, it tends to deform over time, and so you'll get device migration. It doesn't mean that it actually breaks through or pops out of the rib, but the rib actually tends to deform to the device itself. And then specific to this implant, you can get, if you put it too proximal or too lateral, you can get a brachial plexus injury. So you have to be careful when you're putting that in. And then finally, the magnetic growing rods. This is a distraction-based system, again, similar to the traditional growing rods, but it's got a magnetic actuator, which is the larger sort of middle part that you see here. It's really nice because you can do more frequent lengthening, so you're not putting quite as much stress on the implants themselves. The issue is that the smallest actuator is 70 millimeters, and then you can't bend at the actuator or 20 millimeters proximal or distal. So you have to have a pretty flat surface for quite a long portion of the back in order to be able to implant these. If they work, though, they're quite nice. You do get a lot of kyphosis at the top, so you get a lot of proximal junctional kyphosis. We used to use them a lot. I think the pendulum is swinging back towards starting to do more casting and bracing and halo treatment because we are seeing the complications that we were seeing with all of the other growing techniques that we have had previously. And so the nice thing about the growing rod is that actually, despite the fact that it's very expensive to put in, overall the cost is not as expensive because you're not returning to the OR quite as frequently. You have fewer planned returns to the OR, but the unplanned returns to the OR are the same as a traditional growing rod. We're seeing a lot of wear debris when we're taking these out, because we do take them out. And then you can have fractures at the actuator or the rotator stall. So if this plays, you can see one that I took out 2 weeks ago, that the rotor just totally broke and wasn't functional anymore. And so we're seeing a lot more of that. There are contraindications to this. If you have poor bone stock, if you have a pacemaker younger than 2 or very small. And then most of the time we won't implant them if they need a lot of MRIs. If they already have a lot of kyphosis, they're not great candidates for this if they have a short trunk or if you can't get your soft tissue coverage. And when you're thinking about these devices, what it really comes down to is the physics and resisting the bending, the torsion, and the axial compression that they're going to see, and then deciding what kind of rod and implant you want to use. So when thinking about the rods, we know that the stress concentrates at the apex of the deformity. Actually, the cross-linking tends to worsen the fatigue life, and you have a higher rate of breakage if you use something like stainless steel, whereas titanium is better and cobalt chrome is even better. So you need a little bit of flexibility in the system, otherwise you tend to see a lot more breakage. And you'll always, in all of these systems, the law of diminishing returns definitely applies. So you get your maximal bang for your buck the first time you put it in and the first time you lengthen. And over time, you need to exert more and more pressure to get less and less lengthening. And eventually, you get sort of what we call an autofusion. And we think about 85% to 90% of people who undergo these lengthening procedures have that. And that's where the spine fuses, despite the fact that we didn't open it up to try to fuse it in that position. So for our kid with the diastrophic dysplasia, you can see it looks like the rod on the right has disengaged, but actually it's just the rib drift that you're seeing. So it is still in the rib bone, but you can see that the child is kyphosing over the top of that. And so we took her back and we placed new rods. We actually placed new hooks as well. And she continued to have this significant kyphosis. The best way to sort of try to prevent that is to go to T2 level. I think for her, we were at T3. And then at the bottom, going below L3 helps prevent that as well. But she started with quite a bit of kyphosis, so her risk of kyphosing over the rod is quite high. So when we think of whether or not to use rib-based versus vertebral fixation, rib-based, you're more likely to get this proximal junctional kyphosis, but it does avoid the spine, and so it leaves you a little bit of a bailout in the end. You will see this rib drift, and then with the rib drift, you get more prominence of the hardware as the rib tends to drift posteriorly with the implants, and then you get the proximal junctional kyphosis. So you'll see that's where you get some of your skin breakdown that we see. In contrast, vertebral fixation is great. If you have the kyphosis, it's better at controlling the sagittal malalignment. However, you can get screw migration, and that about 50% of the time that screw migration is medial. And so while a medial migration may not cause any sort of catastrophic injury, it could. And so that's something that we worry about. And if you see the implant pull out, then there's a little bit less bail out rather than if it was a rib-braced fixation. So when you're thinking about doing these constructs, there's some pearls that sort of work for all of them. Really, you want to make sure I put preoperative nutrition at the bottom, but that should be at the top. So whenever you're considering doing that, making sure that you look at the whole patient, make sure that they're ready. This is never an emergency, and so the patients should be primed up and ready to go to try to avoid as many complications as possible. You want to avoid any sharp transitions. When you're bending the rod, you want to avoid notching it so that your risk of fracture is decreased. You want to try to decrease your unsupported working length. So the longer the working length is, the more points of fixation you need. You'll need the largest rod diameter that you can put in, so that over time you'll have to continue to change out the rods for a larger rod. Previously, we used to do single rod constructs. The best way to prevent rod breakage is actually to use a dual rod construct. So a single rod is very rarely used anymore. And when you're putting the rods in, you want to make sure that you contour in quite a bit of kyphosis because they're always going to want to kyphose over the top. If you're doing a traditional growing rod, this is, again, it allows continued spinal growth. It actually controls the curve very well, especially if you're using vertebral fixation. But again, you'll see complications in about 50% of your patients, which is quite a lot. You'll see complications more frequently if you use a single rod, if you put it subcutaneously instead of submuscularly. If the children are younger and the more lengthenings you do, again, the higher risk. If you're doing the vertebral expansion, again, this is really great for thoracic insufficiency syndrome. It helps you address the rib fusions. It improves the lung volume for these kids. But when it's transitioned over to idiopathic early onset scoliosis, you see a lot more hyperkyphosis. Overall, compared to the other modalities, you see less curve correction, less thoracic height gain, and there's a lot more wound complications. So it tends to be not as widely used for idiopathic. And then the magnetically controlled growing rods, it's fantastic. You can lengthen them in the office every 2 to 3 months. It's not invasive. You have less anesthetic exposures. A lot of these kids are going back and forth from the OR for other reasons because of their underlying disorder. You get a very similar curve correction. You have a similar unplanned return to the OR, but I would argue that that's acceptable. It's just you have to be able to have the flat segments so that you can implant these. On the syllabus, I put this this chart so that you can refer back to it, just as who might be a good candidate for which of the options we talked about. And then our patient here, they're about 9 years old. Here you can see that they've had multiple revisions of their rib constructs and their rib hooks. The balance isn't great, but it's not terrible. She's able to walk and be a normal kid. She still has her trach and her G-tube, but overall doing pretty well. You can see that, let's see if this plays. She did develop some rib fusions, which is sort of driving some of her deformity probably. She'll need some 3-column osteotomies to help with her final fusion, but that's where she is. So thank you so much. This is my daughter learning how to put pedicle screws in the spine.